Okay, thank you, Mama. This is recording progress. Okay, good afternoon, everybody. And then I will be talking about principles of trauma management. I'll just share my screen. Okay, can you all see the screen?
Yeah.
Yeah, okay, thank you very much. Okay, so it's going to be principles of trauma management, and that I'm going to talk about today. I'm not giving a didactic lecture about what you need to do. A lot of people die from injuries sustained from trauma. What I'm really concentrating on about is how do you minimize the mortality from that? And the objective of this talk will be to outline the principles of trauma management that optimizes survival. I'm just trying to get rid of one of the screens. Okay, that's it. That optimizes survival. The leading cause of death in Africa in 2019 is, as you can see up here, trauma is a nice leading cause of death. So apart from ischemic heart disease and stroke, non-infectious cause of, the third non-infectious cause of death is road injury from trauma. This is not a worldwide problem because let me rephrase that. It's a worldwide problem, but we're overrepresented in this statistics. Almost 4.5 million people die every year around the world from injuries sustained from various traumas, and 33% of these are due to road traffic accidents. You have deaths due to suicide, and 10% of deaths due to homicides. That's quite a lot of homicides. But the important part that we all hear about are wars and conflicts, and yet more people lose their lives to road traffic accidents than die from war and conflicts around the world. The next line is the most important part, that 90% of global injury-related deaths occur in the poorest countries. There's a lot to it about just the fact that people are poor, because even within rich countries, the people from poor economic background have a higher rate of fatal and non-fatal injuries than people in wealthy background. So there's quite a few of behavioral aspects to all of this, not just about money. The way that people, and I'll just come back to define that in the next couple of slides or so, the way that people tend to generally look at the effect of illness or injury is disability adjusted life years. So that from trauma, 79 million life years were lost in, and this is 2019, going back to 2019, I didn't put the dates there, but in 2019 globally. If you look at the low-income countries, it's 14% of the global total, and low-middle income countries, it's 42%, and then it decreases onwards. But look at the upper income countries, is less than 10%. But that doesn't tell you the whole story, because this is just purely on population. But if we look at per 100,000 people, in low-income countries, it's 1,724 adjusted life years that is lost to trauma, compared to, it gets lower the richer you are, and compared to 488 in high income or upper income countries. And this, on the latter side of that is the ratio to the high income, twice in upper middle, 2.4, and 3.5 times of lives that are lost. And the consequences for economics in poorer country it's even worse that you can do. And what disability adjusted life years just means is that if you die, so that's the YLD, if you die before your time, so let's just assume it's not that, but let's just assume the life expectancy is 72 in the West. I think in Nigeria, it's still about 51, but you die at 30 from whatever cause. That's the years lost. That's the years lost to life. So you die at 30. What you then have is that instead of reaching 51, you've lost 21 years of your life. And that's important part again, because even though our life expectancy is lower, our daily is still higher than the rich country. So we are losing a tremendous amount of people. And then the years lost lived with disability, you don't die, but you've got a broken leg or you've lost a leg, you can't work and all of that. And you do that at 20, means that for another 30 years or so, you're working at less capacity than that. And the combination of those gives you disability adjusted life. Now, what's happened? This is a bit of an earlier statistics. So this goes from 1990 to 2030. And the only reason I presented this DALI is more about the changes that have happened over the years. So these top areas, the DALIs have improved. So as the years between 1990 and 2013, that's almost almost half a quarter of a century, they have improved their DALIs, and this area is Europe, United Kingdom, Australia. If you look at all of this, they've improved their DALIs by over 50%. But if we come down to Nigeria is down there, our DALI is actually worse over those 25 years. I mean, and instead of going down to South Africa or Southern Africa, where it's almost 30–40%. So that even though we are how much we lose in terms of road traffic accidents. So it's an important issue, and I think it's something that we need to raise. What are the reasons? And I think I've written that pre-trauma, obviously behavior, drugs, recklessness, speed, seatbelt, infrastructure, the roads, vehicular, the state of our cars. I'm sure you've seen so many cars with tires and that has absolutely no spread on them, or they've been driving them for almost 30–40 years. But the part that it starts coming to what the topic of this talk would be is what happens at the scene. Many people have accidents, and we've seen major trauma. There's nobody or no ambulance or minimal ambulance to pick them up. So some of these patients get carried by relatives, or and I think that one of the things we've just seen recently was the shell. I think it was a fire in somewhere in Lagos, and people with severe degree of burns being left in shop trolleys while they were waiting. I think there's got a video of that is going on. Or one of those injuries that happened, I think it was in Kenya when it does, and people were being picked up on rickshaws to take them to hospital. Those are all things that contribute to the scene, and we'll talk about that. Apart from that, the difficulty, what happens in rural areas, how do they get to trauma centers, and those are all of the things. And I think a lot of what we're going to be talking about today is what happens at the scene and what happens in hospital. These are the places that we can obviously make better. So I'll look at briefly the principles of management at the pre-hospital level, the emergency room resuscitation, and partly, very briefly, very briefly, definitive management. And I apologize for a Birmingham spelling of management there. Now, what we know is that when an accident happens, there are 3 peaks of death. Those are going to die within minutes, and that's what this first curve is. They're going to die within minutes. They're going to die within a few hours. Most of these injuries are not preventable, also are not survivable, and even for those that are survivable, you don't reach the appropriate treatment center in time. So those are going to die. largely we don't have any control about what we do of that. The ones that we have control over the most, the early deaths, those are people who would die within the first 4 hours of the injury. That we have control over, and that's what this is going to be talking about a wee bit. And of course, late deaths. We really have control over that as well. And this time, this first peak, this first 4 hours, particularly the first hour, not only affects the survival in this peak, it also affects the survival of the second peak. So what's the type of injury? And I think they're predictable, who are going to die within minutes. Huge laceration on the brain stem is transected, high spinal cord injury, the heart, any major blood vessels. I think most of these people are going to die. If then one, either what doesn't matter what we do, or they don't have treatment within the hour or within half an hour. The ones that we can primarily do an awful lot about are those that die within the first 4 hours. And this includes people who have subdural epidural hematoma, pneumothorax, hemopneumothorax, pelvic injury, and other organs that are associated with significant blood loss, the spleen, the liver, mesenteric tears. And I think that the whole point about what I want to get across is how we manage, or how we recognize these patients and do something about them. The third peak are the people who are going to die of sepsis or multi-organ failure. We probably have a lot that we can do about preventing the sepsis, but occasionally, if they sort of completely mangled up and there's so much contamination on the side of the accident, that might be us running behind the curve, although we can still, a lot of patients, we can prevent multi-organ failure and I have to add sepsis in this first 4 hours if they're properly managed. So the first hour of care after injury is characterized by the need for rapid assessment and resuscitation. And as I've said earlier, this hour is determinant of survival, both of the second and third peaks. And the way I'm going to go with this talk is not me telling you what you need to do in these various phases, is looking at what you need to look out for, what the pitfalls are, and what you need to be cautious about when you're doing, when you're assessing these patients. Now, we start with pre-hospital treatment. The principles of managing pre-hospital treatment are airway maintenance, and that's the principle of any trauma or any acutely unwell patient. If they can't breathe, if oxygen is not going, they're not going to survive. They're going to lose everything. And obviously, control of external bleeding and shock. Immobilization of the patient, and that's important. And I think this is particularly where people with good intention, when patients who have multiple trauma, they drag you out of a car and your spinal bones that's broken but not severed your cord, and finally does the job. So obviously, it's more about managing with log rolling, spinal boards, splints, neck braces, and things like that, and immediate transport and identifying where these patients need to go to. Now, behind every management of things, of any condition, is always going to be having a plan. What do we do? How do we triage patients? So if patient is unwell, we need to identify who we need to do something about. And I've put in priority one. Priority one means they need immediate life-saving treatment. And I think a lot of this will probably succumb. It depends on the expertise of the people who are at the side of the scene, who can do things with burn, like most of these people will succumb at the side of accidents. Those that need urgent, significant care within 2 hours, and priority 3 are those who management can be delayed. Doesn't mean they don't have severe injury, but at the time they're not of concern. Then the last group, those who are dead, we want to be able to recognize somebody who's dead. That's an important thing because you don't want to start resuscitating them when there are other unwell patients around. So what this pre-hospital triaging has shows, the question, can the patient walk? Yes, if they can walk, chances are, and it's not definite, that you can put them at low priority, walking wounded, shift them across to the green area, and carry on with the next person. Is the patient breathing? No. Even after you clear the airway, you put something in, they're not responding, obviously you probably decided they're dead. The reason I say that cautiously is because we have seen from time to time people who are in the morgue and rise up, but obviously a competent person should be able to know who's dead and who's not. If the patient is breathing, is that without your help? Or is it after you open the airway, clear the airway, put your fingers in, lift up the chin, that's when they start breathing. Then, if that's the reason, then they become immediate priority 1. You want to start shifting them out of that place. And there are few controversies about whether you carry the patient immediately straight to hospital or you do resuscitation on the site, but I won't go into that. So if after you needed to open the airway, pull the, lift the chin up, they are breathing, get them straight to hospital. If you don't have to do that, but the patient is breathing, then you go to your next line and ask yourself, what is the respiratory rate? Over 30 or less than 10, again, scoop them straight to the hospital. And I think this mechanism is helpful if you have multiple injured patients in deciding what you need to do, who's going to get into the ambulance while you're waiting for other ambulances to come. But if the respiratory rate is within 10 and 30, and I have to say, by the way, if they've not been running, respiratory rate of 30 is high. But for the purposes of injury and triaging, then between 10 and 30 is acceptable. So respiratory rate is the first thing that you're looking at. Airway, respiratory rate, and I'm sure that you probably recognize that that's ABC that we're going down. If it's between that 10 and 30, you then want to look at the pulse rate. Pulse rate less than 40 or higher than 20, again, priority 1. That's the triaging. That's the way that you are assessing patients. And obviously, by the time you come down that cascade, it's the pulse rate has been 40 and 20. Capillary refill time is greater than 2. Then they need something done within 2 hours, but you can wait for the second load of ambulance while these ones are going to the hospital. This is a useful thing to know, useful thing to have at hand. You're going to, this essentially looks at what we've just spoken about. And this gives you a revised trauma score. It's the same thing that what, and if you look at this revised trauma score, is looking at the respiratory rate. Well, what we just spoke on the last slide doesn't have Glasgow Coma scale. We're talking about respiratory and blood pressure. But this has all 3. And if you look at it, it's a very tight scoring. 4 maximum there, 4 maximum there, 4 maximum there, and that's 12. So if the individual is 12, then they're priority 3. Walking wounded, but doesn't mean they don't have significant injury, but just means you can prioritize others before. But a drop of only 1 point, just 1 point. So any one of this that is abnormal and within not within the acceptable range, they're 11. And that immediately says they need something done within the next 4 hours. And a drop of only 2 points is life-threatening. So it's a very tight thing to use, and that's how you need to assess. If you have these ways of assessing or triaging, then you will be able to identify patients that need immediate attention. What I've put here, I'm not going to go through all of this. It is from ATLS, and I think I'll ask you this a bit later about whether you guys know what ATLS is about and whether it's been offered down across the continent. Step one, if we look at step one, and also apart from the fact that, let me just go back, the triaging, what this tells you is more about where do they go to? Do they go to a trauma center? And again, that's obviously a huge bit of a problem for many people because many patients will end up in a small general hospital. Revised trauma score, we've spoken about that, and I think that any of this that is positive, Glasgow Coma Score less than 14, you have to remember that in revised trauma score, the Glasgow scale was the first one that gives you a normal number is 13, 14, 15. Whereas if it's less than 14, or respiratory rate is, as we said before, they need to go to a trauma center and you need to what's called get the trauma team ready for the patient. We'll come into that. But more importantly, what you also need to do is the mechanism of injury. Oh, sorry, what injury they have at the time. So you need to assess them. Flow chest, and we'll come to that again. Big injuries, major limb injuries, penetrating trauma, anywhere, paralysis, pelvic fracture, they need to go to a trauma center. And I can see how that is going to be a problem. Again, in remote areas, how do we transfer them to trauma center? But we'll come back to that as well. Even if you can't get them to a trauma center, what do you do? So once the injury are not totally obvious, the next question would then be, what's the mechanism of injury? Car traveling at 100 miles an hour, collides with somebody, and a passenger is ejected. They've got serious trauma. There's nothing there. Or somebody's died in that car. Those are things I would say, we need to get you straight to hospital. Speeding at 40 miles an hour. 40 miles an hour is not a lot. Okay, but if your initial speed when you crash is over 40 miles an hour, or there's a huge dent in the car, or passenger moving out, all those things signify the likelihood of major trauma. It takes 20 minutes to get somebody out of a car, or the car rolls over, or you're on top of a building and you fall 6 meters. All those things are significant in terms of injury, they can likely injury. And I think one of the slide, we'll come to that. The slide for cars tells you the type of injury you can have. Again, you need to get them. Now, just go back that slide. The other part is that having done all of this, and the answer is no. Okay, so we're coming down. The answer is no. Again, you're going down the cascade, and we'll come to this fourth part. Is that the patient is younger than 5 or older than 55, which means I'm included in that. You still have to take them into hospital. And we'll come to the reason for that. And obviously, pregnant women, immunosuppressed patients with cardiac disease, and we'll come to that a bit later, and diabetic, and people with morbidity, essentially. People need to get them into hospital because that can affect how they react to trauma. So the other aspect of this, and I think we just probably covered that in the sense that it told you what sort of accidents they've had, and you go down that cascade. But what all those things signify to people is that it tells you what sort of injuries you might expect. So you're in front of a car and your steering wheel is bent, or your knee makes an impression on your dashboard, or you have your face into the windscreen. the type of injuries that you may have are all on the right. And that's obviously something that needs to be suspected. And that's the message that's going to be transferred. So usually when you hear from an ambulance person, ring to the casualty, ring to the trauma patient, they'll tell you, car driving at 40 miles an hour, they've crashed, somebody has died. The person that is coming to you we're going to the patient obviously collapsed on top of the steering wheel and was compressed there. So immediately what's going through your mind is, oh, these are the injuries that individual can have. If the injury is from the side, so the injury is from the side, you're speeding, but somebody just drives straight into you, or you can still have a lot of injuries. And this includes very severe injuries like flail chest, pneumothorax, traumatic aortic disruption. And these are all injuries that, particularly aortic disruption, that you may not survive. And obviously spleen, kidneys, pelvis, or part of the injury. If they hit you from the back, a lot of the time, usually means you stop fast. Most of those things are cervical injury and soft injuries to the neck, and I think you know that. If you're ejected from a moving vehicle, then you've got serious problems. And mortality, and usually if you're a pedestrian and you're hit by a car, you're open to so many injuries, and that's down there. So I think that in the previous slides, if we move from the triaging, so what's important about the site, about the accident site is, one, to prioritize patients appropriately, to get the people who need to be in theater pronto, to be in hospital pronto, in hospital, to recognize them. And you do have instruments that you can use. The ones that need to be there, but not immediately, another 10, 15 minutes so they can get the sicker ones, that's fine. So what happens when you now phone hospitals to say, oh, I've got 3 injured patients, is that you need a trauma team. The level of the trauma team that you have in waiting for the patient, and I've written that the team is waiting for the patient. So the patient doesn't get there before you get the team out. Usually when I used to be working A&E, or when I was still a registrar, we would be waiting at the door for the patient to come in. So we are waiting for the patient to get into hospital. And we have a group, the trauma team, they've had an accident, they've given you reverse trauma score, they've given you the state. So the minimum trauma team is that you have 3 doctors. Most of these are all emergency physicians, 2 nurses, and a radiographer. But there are multiple injuries. Some people are very unwell. You suspect they're either bleeding or something like that. Then you need an enhanced trauma team where you have not just what you had before, but you have another nurses, but now you have doctors from orthopedics, general surgery, and anesthetists all waiting for the patient. But obviously for those who are very unwell, you need intensive care physicians. And I think it's important. And this is a very important process, and it saves lives. The team is waiting for the patient. Management is horizontal, and I'll come back to that on the next slide. I've written multiple casualties and mass casualties, and I think that's an important part, because if there are multiple casualties and people, and we just had one in Durham, I think last week or the week before, then what you then need to do is get more people. So they're not coming to casualty, but you might say to theater that is ongoing that, can we not take anybody else to theater at this moment because there are multiple injured patients coming and we may need theater? Or it's Saturday or Sunday, can we phone people from home to come into hospital or on standby who are not on call? And I think all those things, you have to have all those systems in place You have to have the systems in place before those things happen, so everybody knows what they're going to do and what the policies are. So when I say this is horizontal, I hope you can all see this, is that all those people that I've spoken about in the last slide are there with the patient. So things are happening simultaneously. There has to be a team leader. There has to be a team leader, usually in casualty, could be the registrar, could be the consultant, doesn't matter, but the person who knows what they're doing. There has to be a team leader who controls everything. Appropriately trained, that team leader controls everybody. And that's there. Then you have the person who's responsible for the airway. That's either also emergency physician or an anesthetist if they need to. You have your nurses there, you have your resident there. While you're checking the airway, you're doing what you need to do. Somebody's there putting a line in, putting the drip up, taking some bloods. You have somebody there as well who is assessing other parts of the patient, but this is all in a coordinated fashion, and everybody needs to know what they're doing. And if you need the surgeons there, the orthopedics there, a lot of the time we are standing out here while they're all doing what they're doing, looking at the vital signs, and obviously we're trying to decide, because part of your primary survey, and we'll come to that, part of your primary survey is, oh, does this patient need to go to theater now, so that we can save the life of the patient. So it's a very full slide, and obviously this slide will be on the site for you to see later, but it's just to tell you how that place is organized and how many things are going. It sometimes look chaotic, but this is obviously always well coordinated, and that's why all these people need to be waiting for the patient to come. Here you have the radiologist who has a portable image intensifier. They can do an X-ray on the patient if they need to. We have somebody who is competent on fast scan. I hesitate about fast scan, partly because I'm not a big fan of fast scan. And by and large, we have X-ray, CT scan next door. Okay, so that once we stabilize patient, we can do head to bottom CT scan. But obviously, if it's far or the patient is not stable enough, fast scan is helpful. What else do I want to talk to you about on this slide? Okay, so that I'll just get you to have a look at the slide, so I don't spend a lot of time, because there's a video to watch on the slide. But I think what this is all referring to, there's so many people there, they all have to be there so that things are happening in real time, and trying to get the patient out of that place. So in going through the primary survey, which let me see what I'm going to do. Well, the primary survey is about airway maintenance with cervical spine protection. And we'll come into what the cautions, things you have to be cautious about in all these groups, and also the pitfalls of them. But I'm not going to go, apart from the next slide, I think, I'm not going to go into what you're doing in all those things, because I'm assuming that you should know this. Breathing is breathing and ventilation. Circulation with hemorrhage control, disability and neurological status, exposure, completely undress the patient, but prevents hypothermia. Okay, so what this next slide is going to do is just a scenario. I'm show you just a scenario of assessing the patient. This is only concession I'm going to make. Sorry, there's a conversation going on. Oh, apologies. Okay, just to say, I'm starting again. There are two voices. The bloke who's examining the patient, he's talking, but there's a voice outside who's telling him the outcome of his investigation. So he's reacting to what the guy is telling him to do. Okay.
This is Daniel Johnson, a 25-year-old student. He was knocked off his bike by a bus and has been brought into A&E by paramedics.
Do I have any assistance?
Yes, there is an ED nurse who is able to help.
So you can hear now.
I put on my personal protective equipment.
Yes, thank you.
Gloves.
Okay.
Is it safe?
Yes.
Yes, there is no obvious threat.
Hello, Mr. Johnson. Can you hear me?
Yeah,
Are you in any pain at all?
yeah, quite painful all over.
Okay. Can you open your mouth for me, please?
There is nothing abnormal in the mouth.
Looking, listening, and feeling.
The chest is moving. There are no abnormal sounds, and you can feel breath on your cheek.
Nurse, could you give me some oxygen, please? 15 litres through a non-rebreather mask. Thank you. And do you know how to stabilise the C-spine using a collar?
I don't, but I have one here.
That's great. Could you come and hold the head stable for me, please? So put your hands over mine and hold the head. Thank you. So I'm checking the collar size is correct. And that is appropriate. Okay, Mr. Johnson, putting a collar on you now. And so secure your head in place. Very much, hold them steady. I'm just going to tape you into place as well. Fine, you can let go there. Okay, I'm satisfied with the airway. I'm going to move on to breathing. Nurse, would you mind putting on a pulse oximeter, please? Well, I'm going to have a look at the neck. Are there any obvious abnormalities in the neck?
No, there is nothing abnormal of note.
And does the trachea appear central? And is there any crepitus?
Yes, it's central and it appears normal. There's no crepitus.
Exposing the chest, are there any obvious injuries?
No, there is no obvious chest-borne injury.
And is breathing symmetrical on both sides?
Yes, it is.
And what's the respiratory rate?
16 breaths per minute.
Feeling around the back. Is there any blood on my gloves?
No,
Move on to percussion.
normal percussion, normal percussion, normal, 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 normal.
Breath sounds.
Normal breath sounds. Normal breath sounds. Normal. 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 Normal heart sounds. And the pulse oximeter reading is 99%.
Okay, thank you. I would also like to order a chest x-ray and a pelvic x-ray at this point. Okay, I would like to now recheck the patient to make sure there's been no change. Hello, Mr. Johnson, can you still hear me?
Yeah.
Yeah, still okay?
Yeah, just about.
Okay. And I've just checked the pulse oximetry and there appears to have been no change in the breathing, no change in breath sounds.
That's correct.
Okay. I'm satisfied with that. I'm going to move on to circulation now.
Proceed to do so.
Okay. What's the patient's appearance?
They appear pink and well perfused.
Okay. I'm going to take the patient's pulse. Are you okay to check the blood pressure, please? Thank you.
The pulse is 72 and regular, and the blood pressure has come back at 120/80.
Okay. Right, I'd like to insert 2 large bore cannulae into each antecubital fossa. Thank you very much. And from the first one, I would like to draw blood for group and save, FBC, LFTs, Usenes, amylase, and clotting. I would then like to run a bag of warm saline through each of them in order to maintain vacancy. Thank you. Is there any evidence of external bleeding at all?
Blood on the bed or on the patient.
I've already ordered the chest X-ray. Is there any evidence of abnormality in the abdomen or pelvis?
No, there is no bruising or tenderness.
And in the legs?
Elias, can you switch off your microphone, please?
From the results of my findings so far, the patient is hemodynamically stable, and as such, there are no further investigations I would like to perform. Okay, so I'm going to quickly recheck A, B, and C again. Mr. Johnson, can you still hear me?
Yeah, still here.
Fantastic. And having a look at the obs, has the pulse oximetry changed?
The pulse oximeter is still reading 99%.
Okay. So moving on to disability, can you wiggle your fingers and toes for me, please?
Yeah.
Great. So the patient is alert and responding to my instructions, and as such, he has no obvious gross neurological defect. Could you do a capillary blood glucose, please? Meanwhile, I'll shine a light in your eyes here.
The blood glucose is normal. The pupils are equal and reactive to light.
Okay. Again, because that's normal, I'm going to move on to exposure. I'd like to expose the patient fully and check to see if there are any further signs of injury.
There are none.
Okay. Would you check the patient's temperature as well, please? Thank you very much.
Patient's temperature is 37 degrees.
Okay, that's normal. So I'd like to, having exposed the patient fully, cover them in blankets in order to maintain that temperature. At this stage, I would also like to be considering an ECG, an ABG, a urinary catheter, and a gastric catheter. And I would now proceed on to do a log roll and to perform a secondary survey.
Okay. This is Daniel Johnson.
Sorry, I'm trying to get back. That's the end of the okay. So important things to take away from, oh, sorry, I think I've lost my video. Okay, I'll just continue. Can you can still see my screen, yes?
Yes, we can.
Okay. So important thing to take away from that, obviously, it's a simplified thing. It is it's an injury and that was not major. It was one person that was there, but as you can see, at some point, he was putting the venflons in when they got to circulation. But if you have a major trauma and you have the trauma team, that's already in, and the patient's probably already having fluids. So I think it's a simplified version. But important things to take away from there, you can see some words after the airway, all the things that you can do, how you can intervene after breathing, the same thing, so that you can intervene to actually treat the patient, either by chest drain or possibly surgery at that stage because of patient instability. But more importantly as well is that after he finished airway and breathing, before he started circulation, he went back to airway and breathing again. And when he finished circulation, before going to disability, he went back to airway and breathing again. And that's the important part, that you have to keep on reassessing this patient as you go along to make sure that they're not deteriorating. So what are the things that you need to be cautious about when you're looking at the airway? You obviously, the cervical stabilization was well done. Not only did they put the neck collar, you have 2 rows by the side of the head, and you have tapes across all of this. So you need to prevent excessive movement. You have to assume if there's multi-systemic trauma or altered consciousness, or there's a blunt trauma above the clavicle, there is a cervical injury. You have to assume that. And the fact that when he said, move your legs, wiggle your toes, and do all of that, that, even though they were normal, doesn't exclude cervical injury. Now, until it's imaged and it's cleared, you haven't excluded cervical injury. Obviously, pitfalls, equipment failure, that shouldn't be a huge problem. But for patients who are obese and you can't get either an airway in, or you, for some reason, you need to do a tracheostomy, then that may be. Elias, can you put off your microphone? Muibi, can you put off your microphone, please? You have to, so there's a difficulty, and there might be a difficulty in getting that done. But for some patients, if you don't know they've got a laryngeal fracture, or they got an incomplete upper way transection, and sometimes it might not be easy to recognize that, and you try to intubate them, you might cause either complete airway occlusion or transection, and that's a pitfall in those settings. Okay, I need somebody to tell me what you can see on this chest X-ray. Oh, sorry, on this chest X-ray and CT scan. Anybody? If we don't talk, I'm going to call somebody. Is anybody still there?
Yes.
Okay. Okay, I did what you. Do you want to tell me what you can see on this, on the X-ray?
So it does appear there is absence of lung markings on the left.
Okay.
With contralateral deviation of the heart and the medial sternum.
Good.
Maybe there is tension pneumothorax, I suppose, in this case.
Maybe there's tension pneumothorax, I suppose, in this case.
Or maybe.
Yeah, no, that's fine.
Right. I can't see any evidence of the lung on the left at all. I'm wondering if the patient has pulmonary hypoplasia or if it is all just tension pneumothorax.
Okay, so if it's all just tension pneumothorax, and if it's tension pneumothorax, what's wrong in the context of trauma?
That is life-threatening, is potentially life-threatening in this instance.
Yes,
And
okay.
intervention has to be done right now. And this has to be treated right away. Otherwise, the patient is just going to die.
Yes.
And one shouldn't move on from B until that is sorted.
So what's wrong with the CT scan?
This CT should never have happened in the first place.
That's the point precisely. So the CT should not have happened because almost the entire lung is wiped out. So it's a clinical diagnosis. And as you can see, when the guy was doing the assessment on the video that I showed you initially, just hang on a moment. I need to stop sharing my screen. Oh, sorry, that's fine. Okay. Oh, it's okay. Okay, that's fine. Good. I'm fine. Now, when the guy was examining, he put his finger on the trachea. They told him it was central. He percussed the chest. He listened to the chest. And in those instances, this diagnosis should have been made during the breathing part, and the treatment should have been done there and then. Because obviously you will expect this guy would be quite unwell. So you're right, it's tension pneumothorax, and the clinical diagnosis is during primary survey, and the treatment should have been during primary survey. What you have is that there's air going in, but it can't go out. There's increase in intrapleural pressure. The thoracic cavity is fixed. It has a fixed volume. And if that keeps on going, and with everything being displaced, obviously you can impair venous return, you can cause circulatory collapse, and the patient can die. There's so many things. There's so many, you don't, I mean, the times it's not as bad as that, but that was bad. And the CT should not have really a reason they should have treated that with a needle in the second thoracic space, and also a chest drain at the time. So what are the other things that cause acute impairment when you're looking at respiration? Tension pneumothorax, we've said, flared chest, massive hemothorax, and open pneumothorax. All these injuries should be identified during the primary survey. Most of them, and I think when you saw my earlier slides, should probably be, particularly flared chest and tension pneumothorax, probably even been identified at the site of injury, but definitely during primary survey, and they should be identified so that definitive plan towards these things or immediate management of these things are started. Now, the other pitfalls for ventilation is that if the problem with breathing is due to pneumothorax or tension pneumothorax, and you intubate the patient and you're bagging them vigorously, you can actually make things worse as well. So that, oh, they are not breathing, they need bagging, but you haven't done a proper clinical assessment. You start bagging them and you're making things worse. And that's where the investigation is important. But occasionally you need to be very aware that even if they don't come in with pneumothorax and you ventilate them, you may cause pneumothorax. And that's important that when you ventilate trauma patients, that you also x-ray the chests afterwards. Circulation. What are the problems you can have? Let's just take a young person who's very fit. You're examining them and they've got irregular pulse. Then you have to be certain you have the mechanism of injury, they've got irregular pulse. You have to be suspicious that there might be cardiac dysfunction. Those are the things you need to be aware of. But importantly, you've palpated the carotid or the groin, and these things are not there. they've got a low blood pressure. And if you go back to the revised trauma score, these are people that need things doing immediately. So there are a lot of simple things that you can do, even without all your equipment, that tells you this patient needs treatment. There's some studies that say, oh, this thing is probably overestimate your systolic blood pressure. So some people are saying that even if your carotid pulse or radial pulse is palpable, your blood pressure may still be low. But it's a good guidance to know that if you can't feel the radial or the femoral or the carotid, these patients are sick. They need immediate intervention. Tourniquet is obviously another one. Unless you've got a limb, an amputation with the vessels exposed, you want to shut off the blood supply. You don't need tourniquet. They cause their own problems, and they cross tissue, and they call distal ischemia. And distal ischemia can lead to other potential problems moving forward. Now, the things to also remember about when you do your blood pressure and pulse, elderly patients, and I think we're beginning to start talking about the individual is over 60, 55, 60, they have limited capacity to increase the heart rate. So they may not respond to blood loss as you want them, as you think they ought to respond. You need to be aware of that, and be aware of that, you can better manage these people, and their blood pressure may not correlate to the cardiac output. And we'll probably, and at the bottom end, you can see for various reasons, they may be on various medications and that you're not aware of at the time of the injury that may contribute to this. The other side of this are children. And I think, and the next slide today said athletes, but children, young adults, they may not, they have abundant physiological reserve, so that even though they've lost a lot of blood, they may not show the expected physiological changes and that you have with someone who's lost a lot of blood. And by the time they drop the pulse of blood pressure, things have gone so far, and that may just be very catastrophic. And there may be that you've missed an opportunity to treat them. So you need to be aware of that. Elderly and young children, that they have different ways of that, but also well-trained athletes. Okay, and if you take a long distance runner or a long distance cyclist, they can have pulse at about 40 normally, about 30 normally, huge heart, and they come in and the pulse is about 80, 70, 80, which is normal for you and I. You still think they're fine, but something serious is going on, so you need to do that. But medical history is an important one. Have a read of this, and I'm going to ask, you're going to answer, somebody's going to answer the question underneath. So this is a real life patient, and was my patient a few years back. 23-year-old male, after some alcohol intake, he had an argument with his girlfriend. She stabbed him once in the abdomen, upper abdomen, the previous night. We didn't see him then. He went to casualty. The stab wound was explored under local anesthetic, and they were happy that it didn't go into the peritoneal cavity. But instead of sending him home, they kept him in hospital because, one, he was drunk, and two, you might be sending him back to harm's way. So they kept him to hospital. The following morning, when we got there, he'd been stable overnight. Said he had a bit of shoulder tip pain, but he felt well, remorseful, and he wanted to go home because he was sober. What would you do, anybody? I'm going to call on somebody. Okay, Christian Ugu. Christian?
Yes, sir.
Okay, do you want to answer that question?
Yes, sir. I would be worried about him going home because
Why?
of because of the shoulder tip pain.
Okay, because of the shoulder tip pain, you'll be worried about him going home. So what do you want to do?
I want to have a CT scan of the abdominothoracic CT scan done.
Okay, so you
Yes,
want
sir.
to have abdominal thoracic CT scan done, fine. And that's precisely what we asked for. So we asked for CT scan of his chest, abdomen, and pelvis. And about an hour later, they came to pick him up for a CT scan and he collapsed. What would you do?
Yes, sir. I'll be suspecting that he probably had maybe an injury, a penetrating injury to either the liver or the spleen.
You have to remember, though, that they said they explored the wound in casualty and the peritoneum was not breached.
Yes, sir.
Okay? Yes, sir. What does that mean?
In this case, so it's probably the injury is in the chest, not the abdomen. So and that will the thoracic part of the CT scan will help us in this. But since it collapsed, I will start with resuscitation, and I think he has probably a penetrating injury to either the major vessel in the thorax.
Okay, so you start resuscitation and you go for CT scan. You still go for CT scan.
No, since the patient is not stable, there's no need for CT scan again.
What would you do then?
I will need to explore. I will need to resuscitate and explore this patient. So, patient needs emergency surgery.
Which part are you? Because you've now said chest, and I said abdominal wound stab.
I will say chest.
Okay. Anybody agree or disagree? I need somebody else. Who disagrees with? You've done very well, sir. But who disagrees with you? I'm going to call somebody else. You will not answer me. Oh, Elias Muibu. I've called your name a few times now. Do you agree with your colleague or not that you'll explore the chest? Elias Muibu.
Yes, sir.
Yes, sir. Okay, you look at the chest.
Yes, sir.
Okay, who would look at the tummy? Who would go for the tummy rather than the chest?
So I have something else to say.
Go on.
So it's probably that the injury breached the diaphragm. So if you explore, you can actually explore through the abdomen. Then if there's maybe penetrating diaphragmatic injury, that could explain why the injury is coming from the chest as well.
Okay. Anybody who will explore the tummy instead of the chest? Oh, you said of the chest. Okay, I'll help you out. So what we did was we canceled the CT scan and we took him straight to theater. And it's a knife wound to the abdomen. Oh, my phone is saying which theater? We took him to theater and we opened his belly up. This is a 23-year-old bloke that came in the night before, and they'd explored his wound, and they said he didn't breach the peritoneal cavity. They only kept him because he was drunk, and that's precisely what saved him. Because when we got him there, despite the fact that and that's what I was thinking, I was talking about earlier, that when you're young, you can compensate. And despite the fact that this guy was stable overnight, we had almost 3 liters of blood in his belly. But not only that did we have 3 liters of blood in his belly, the knife did penetrate the peritoneum, but it went at an angle. So when they explored it, the peritoneum had obviously gone out of the way. And what we found was the knife had gone through and through small bowel and into the transverse colon through and through. So it was really a ferocious stab wound, single stab wound, and this guy managed to maintain his blood pressure for over 12 hours before he crashed. So we took him to theater. We actually did repair, it was still very clean, repair all the injuries for him without giving a stoma, and he was young enough to go home. Okay, thank you for that, the two people who answered. So we're looking at the end of the primary survey. Obviously, it's a disability part. We're not going to go too much into that. Okay, Glasgow Coma scale is really what you need to do. But is it responding? Is the patient alert, responding to only to verbal or to pain, or unresponsive? That's what AFPU means. If they have decreased consciousness, you have to reevaluate the primary survey. You have to exclude that they're not on drugs or taking alcohol. And like the guy we told you about, obviously it was because of the alcohol that he was kept in. And if they're both excluded, then you have to assume there's a central nervous system injury until it's proven otherwise. Neurological deterioration can occur very rapidly, so you need to be aware of that. And particularly people with epidural hematoma can have lucid interval when they're talking and everybody thinks they're fine, and then suddenly all hell breaks loose. These are the things you need to be aware. Again, we have exposure part, as you saw in that resuscitation, but the important part is that you don't want them to be hypothermic. And you can see he measured the temperature was 37, covering with blankets. IV fluid needs to be warmed up. The temperature in the room needs to be up. And you might find patients who come in with, what time is it now? Good Lord, with hypothermia, and you might have difficulty warming them up, but this can all cause physiological problems. Now, I'm just going to skip over this, but the important part, and you saw that in that video, is that you do not begin the secondary survey until the primary survey is completed. Resuscitation is ongoing, and the patient is demonstrating that they're responding to it. If they're not responding to it because their breathing is bad, do they have a tension pneumothorax? Do they have blood in their chest? Do they need a chest drain in? Are you going to do a fast scan? Should we take him straight to theater? Those are the questions you're asking yourself that we need to do something about, because they got because what's going to kill them is hypovolemia, for unrecognized hypovolemia from injury and that you haven't attended to, or respiratory problems and that you haven't attended to. And so before you start examining everything, you need to be sure that these patients are stable enough for you to examine them. And if we end up getting to the secondary survey, what you're really looking at is complete head-to-toe examination. Every system has to be examined, as much history as you can get to, as much as you can do. And what it says is you're putting tubes everywhere. Looking in the nostrils, looking at the back passages, looking, as you saw with the other guy when you examine, looking at the back, but that you don't miss. And most of these days now, when you have enough traumas, most of our patients just undergo through CT scan. So the reason I've gone with pitfalls and all of those things are things you need to look for. What can trip you off? But you need to ask yourself questions that this is what I'm looking at. What's it based upon? If your patient's blood pressure is below 90, there's a 50% chance that that patient is going to die within the next 30 minutes. And if you're pouring blood into the patient and systolic is not going up, or it goes up and drops, then you've got to do something about it. It may not be, if you have fast scanning, you're good at it, you may do it. Sometimes we do peritoneal lavage, or you just say, look, we don't know what it is. The chest seems to be stable, but this patient is unstable itself, may need theater. And the type of questions you're going to start asking yourself is the patient going to die within the next 5 minutes if I don't do anything? Is he going to die within the next hour if I don't do anything? Is he going to within the next day? Within the next day, hopefully they shouldn't die because you're going to do something. But the important part is, am I losing this patient? And that's a question that's going to be constantly on your mind when you're managing trauma. And that's the only way that you can try and save your patients. What I've put here, which I'm not going to go through at length, or at all, most of it, is at the time of surgery, we decide that we're going to go to surgery and they're so unwell, okay, because you're all surgeons, it doesn't mean you have to do a 4-hour operation or a 3-hour operation. They're so unwell, anticoagulation is all up the ports, they're bleeding from somebody, say they've got liver injury, you might just want to pack the liver, close the patient up on the table. Or they've got multiple bowel injury, you don't want to start doing anastomosis because they're unwell, or you can just chop off the bad bits, put everything in there as it is, either close them up or put a baguette back on it and come back when they're more stable. Okay, so all of that is still part of trying to get them not adding to their physiological trauma, as it were. And I used to work in Birmingham, and we were part of the military hospital, and it's really quite phenomenal when soldiers are transferred from the war front. These guys sometimes have multiple injuries, and it's really amazing what these guys do on the field hospital. They're just really packing these patients up. We're getting there, finding bowels in all sort of diverse area. But the important part is that they've just gone in, done an operation that doesn't take half an hour or an hour to patch them up, resuscitate them, and get them to somewhere where they can. And I think that's really what trauma is about. Being a good trauma physician is not about this. It's obvious. It's an injury, it's a knife, it needs an operation. Doesn't matter what anybody else says. But that's been a good trauma. I forgot the A on the top end, but being a good trauma surgeon is not about this. This is obvious. It's more about knowing what can go wrong, what's not obvious. When your patient doesn't have an obvious thing like this, what can we do about it? And also being a good trauma surgeon is not about operating on the patient. I think the whole point is that you should be able to operate on the patient, but it's being able to decide that they need to have an operation now, to decide that they don't need a bowel resection or anastomosis, is to decide when they have to go. And that's what being a good trauma surgeon is. Nor is this. Everybody knows this patient needs an operation. And that's a common thing, but I think it's the principle of how do we treat these patients who are unwell. That's what I have for you. Questions? Questions, anybody?
I've got one, please.
Go for it.
Thanks, Funso. A very comprehensive overview of a complex subject. I just had one pure clinical question as a simple plumber. The 23-year-old you described who had shoulder tip pain, and obviously you were thinking of getting a CT, then he collapsed.
Yep.
Do you not have any other signs or symptoms, peritonism or peritonitis or tachycardia, anything else?
Yes, sorry, thank you. When we examined him in the morning, yes, he had some pain in the tummy, but the most important part was the fact that it was the shoulder tip pain, which is completely new.
Yeah.
And one of the things that was quite important was, even though it was inebriated the night before, the person who actually saw him wrote in the note, no shoulder tip pain.
Right.
So we know that it wasn't there the night before, it was there in the morning, but that's true, he had some pain, but I think the most important part was his vital signs were all completely fine. So he had shoulder tip pain, it was been fine, it's been stable, and that's what we thought that, oh, let's get a CT scan, see what's going on. because at the end of the day, we can still manage splenic injury and liver injury conservatively, depending on what grade. And that's why we went down the route of CT scan before he collapsed.
Thank you.
Any other question? Sorry, okay, I'm going to ask you, I'm going to call you Adepoju, but as we're asking questions, please, can I go to my mantra? Can you please all go on the website and put your feedbacks in, please? Okay, it's very important. So can you please put your feedback in? If you need the address, I put the address up now. Okay, Adepoju, go for it.
Thank you very much for the presentation. On the slide that talks about the absolute figures of trauma deaths and DALIs in low income and middle income and upper income countries, it does appear that the low income countries have a very low absolute figures. I'm not sure if I saw that correctly. If I did, I was wondering why that is so. I'd appreciate if you could explain that.
I'll look at the slides now. Come, yeah, go on, and then go on.
Thank you. One or two things to add. In the 10th edition of the ATLS guidelines,
yeah,
they now recommend that for the treatment of tension pneumothorax, the initial decompression should be done in the 4th or 5th intercostal space in the mid-axillary line or anterior axillary line, rather than second intercostal space, mid-clavicular line. And the justification they made to that is that the definitive treatment will be done in that same location anyway, so there is no point sticking a wide bore cannula in the second intercostal space, mid-clavicular line, and that one can easily assess the pleural cavity on that same location as well. So on the 10th edition of the ATLS guidelines, it's now recommended that it should be done in the 4th or 5th intercostal space anterior axillary line, rather than the second intercostal space mid-clavicular line. And people have also started to talk about paying attention to the combined speed in head-on collisions, rather than just, sometimes we say a car is traveling at 40 miles per hour. And then we start thinking, well, maybe it's just a low energy impact and things like that. But sometimes if a car is traveling at 20 and the other is traveling at 30, one needs to document the combined speed if it is known, because that also gives a higher prediction of how much of impact could have happened in the course of that kind of crash. Thank you.
Okay, thank you for the questions. The third one, which is the combined speed, that's fine. That's true. I don't have I don't have a problem with that. The second one, in terms of forcing intercostal, I can see the reasoning, but obviously I'm just a bit of my ATLS was a bit older than yours, so I have to accept that it's changed from time. But I can see the reasoning for using the force space where your chest drain is going to go into. So I think that shouldn't be a problem. I'm just looking at the slides and trying to see what you're talking about. I think the relative numbers is more based on population. Let me just see. So you're talking about the relative numbers. Yes, that's just purely population. And that's why okay. I presented the numbers per 100,000.
Right. I saw that the ones per 100,000 was actually higher for the low and middle income countries compared to the upper income countries. So I was just wondering why the absolute figures were lower for the.
No, it's obviously population based. It's more about the. I mean,
okay.
I think for 2019, if I'm right, the population they used for Africa and sub-Saharan Africa was something like about 700 million, or I think about 1 billion people. And then by the time you go to Europe, which is 2.2 billion and all of those things. So it's more about, that's just a population this. And that's why those absolute numbers don't really matter. The only reason for the absolute numbers is the proportion.
Right.
Yeah, proportion to the overall. But the only way to properly reflect this is per 100,000, which is what I went to do.
Thank you very much. I appreciate that.
You're welcome. Any other questions? Questions before we go? Questions before we go? Okay, well, please, can we do the feedback? The next lecture is going to be in 3 weeks, not 4 weeks, because obviously this was delayed by a week because of me. And I think we're going to have a guest lecturer who's not an Ibadan person, actually not a Nigerian as well, who's going to talk. So that will be in about 3 weeks' time. Okay.
Thank you.
Thank you very much, everybody. Banji, thank you. Ayo, I can see you there. Thank you. And Femi, thank you very much.
Yeah, well done, Funsho. Very, very good. Very, very enjoyable.
Thank you
Well
very
done.
much.
Yeah.
Thank you.
I knew that I will learn something. So, Eshungoni.
Oh, Banji, thank you for the support. And I'll see you next week. Okay, thank you. Everybody, goodbye.